And I have to admit that this presentation topic assigned to me by Professor Prapan is very tough. And I feel that I'm still too young to answer this type of questions. And it should be he himself who provides us the clue to the answer to this question. Anyway, I will try to do my best to address these questions of what remains to be done in the era of the test and treat. And we all know that we are trying to aim towards the 90-90-90 or even 95-95-95 targets by 2030 in order to end the AIDS epidemic. However, we have also gradually realized that in many settings where things seem to be going very well, you have more than 90% of people know their status. You have more than 90% of people linked to ART and has suppressed viral load. But the number of new infections is not decreasing. I used the example from the New South Wales here. And in some of these settings, we also see that the number of condom-less use remains stable or even increasing, and could all of these altogether play roles in terms of continue to fuel the HIV epidemic. In the UK right now, or in San Francisco many years ago, they also face this same scenario. And it depends on how you decide. You may want to do nothing. Now, wait for a few more years until your country gets closer to the 90-90-90, and then look at it to realize that, oh, it's true for my country as well, and then start to think of what to do. Or you can actually think seriously now, start to take action now, and then so when the country comes closer to the 95-95-95, it also come together with the ending of AIDS. I will give you some examples of the actions the country here, Thailand, has been taken in the test and treat period. We know that Thailand is one of the clinical trial sites for the HPTN-052. And it's not until the end of 2012 that the Thai Red Cross AIDS Research Center, together with the Department of Disease Control, MOPH, started the first test and treat project in MSM and transgender women in 4 provinces. And data from this demonstration project proved to us that a facility-based test and treat model like this can be successful in reaching out and identifying HIV-positive MSM and transgender women with a very high rate of ART linkage within a median day of 8 days from diagnosis to ART initiation. And at the same time, this model can be successful in identifying people earlier in their HIV infection with a median CD4 count of around 340. However, at the same time, among those tested negative at the beginning, the rate of HIV incidence was very high. It's 5.3 per 100 person year overall, and almost as high as 7 per 100 person year in Bangkok. When you look at the data at the national level during the same period of time, we can see that from 2012 to 2014, the median CD4 count at diagnosis at the country level is just around 100, or just a little bit above 100. So all of this information together, the high incidence, the high feasibility of the test and treat, altogether has driven us to the major revision in our national guidelines, along with some consistent and strong voices from key people here in this room. So the 2014 national guidelines include the recommendation for ART for all, regardless of CD4 count, along with PrEP as part of the combination HIV prevention package. And you can see that the recommendation or the inclusion of PrEP into our national guidelines is almost 4 years after the results of the IPREX study launched in 2010. And ART for any Thai nationals in our country is for free, but for PrEP it has not been free until this time under the national healthcare schemes. But we have the availability or the access to the generic tenofovir FTC drugs at approximately $20 per month. And the launch of the guidelines itself did not equal that many people would just come out for HIV testing. And many doctors and nurses willing to provide ART for every patient in their own care. In fact, after the launch of this national guideline, our National Health Security Office held a series of trainings for healthcare providers throughout the country, so trainings for doctors and nurses. And I have listened to many professors, academics from university hospitals telling the audiences the controversial messages around treatment for all. So things has not happened or moved very fast after the launch of the guidelines. Fortunately, during the first half of 2015, the data from the Temprano and START study came out, and that settled down the argument around the benefit, the clinical own individual benefit of treatment as prevention. So in May 2015, this time Thai Red Cross along with Department of Disease Control and Thailand US CDC collaboration and USAID came together, partnered to launch 2 parallel test and treat projects in the country. One is the community-led test and treat project. Another one is the facility-based test and treat project. And we added PrEP component as the PrEP sub-study under these 2 test and treat projects. And this has expanded the number of provinces in the country where test and treat strategy has been implemented formally. And let me tell you a little bit about when I say community-led test and treat, what does that mean? I'm talking about having members of communities, in this case MSM and transgender women, being empowered, trained, and qualified to do roles which is beyond that conventional role of doing just the reaching, providing education, condoms, lubricants, or doing recruitment of people into HIV testing, or even just partner with the team from the hospital to do mobile testing to some hotspots. This is just conventional role of what community can do. But here in the community-led health service model, or I will call it for short CLHS model, we seriously empower the members of the communities, and we call them community health workers, so that they are able to perform blood collection, perform HIV testing, support linkage to care, and provide support for treatments such as ART adherence support, and then to provide prevention, including prescribing PrEP or PEP to clients in their community-based organization, and then to retain both HIV positive and HIV negative people in the care. And you can see here that some of the roles that the community health workers can do are even beyond the roles that that the healthcare workers in hospital clinics will do. We are not being very good at doing reaching, recruiting people. We are not very good at retaining people as well. We are just very good at providing care to the people. So you can see here that CLHS is not just a service set up by CBOs, but it is a true partnership between CBOs and government and public health facilities, because the staff from this government and public health facilities are the ones who trained, who provide close coaching, and who provide continuous quality control to these community health workers, so that they can do certain assigned roles in the cascade of HIV prevention and care. And the preliminary data up to now comparing the facility-based and the community-led health service program has proved that these 2 different models reach different populations. As you can see here, the community-based organizations are more likely to reach people who have low education, who are more likely to be amphetamine drug users. But at the same time, these 2 models can reach people with high prevalence of HIV. In the CBO model, they may be able to reach people a bit earlier than those who came to the hospitals. Anyway, the successful rate of ART initiation in both programs are around the same. And when we look at the number at the national level, in 2016 in Thailand, we have around 16,000 HIV testing among MSM and transgender women. And we can see that 42% of those testing are conducted by CBOs under the CLHS model. Or you can say in other words that having CBOs being able to provide HIV testing almost double up the number of HIV testing among these key populations in the country last year. Now let's look a bit for the 1990 targets. What's the progress of Thailand? What we can see here is that our country has done a good progress for the first 90. It has increased from 80% in 2014 to 95% in 2016, with around 70% successful ART initiation and around 80% viral load suppression rate. But this altogether will just give you here just a bit above half of PL-HIV in the country who had suppressed viral load. Looking at median CD4 count at ART initiation after the launch of the treatment for all guidelines in the country, you can see that we have seen a very nice increase in the median CD4 count from just above 100 to now almost 200. However, during the same period, during 2014 to 16, we are seeing a stable number of death cases. And Dr. Tawisap from the Department of Disease Control recently asked in one of the meetings that why don't we see decreasing number of deaths with this quite successful increase in median number of CD4 count of people we diagnose. With 95% of people, we assume that they know their status. So the question and answer to this may be that we still could not reach subgroups of populations, and we could not link them into care. So how can we reach them? Could any innovative ways, including like online technology, will help, or self-testing will help to improve the overall cascade? And in 2015, we have had an opportunity with support from AMFA to launch the online test and treat project among MSM and transgender women. And in this project, the participants can choose by themselves if they would like to receive the testing and counseling truly online. So in this model, you can have online pre-test counseling. And if you decided to have HIV testing, we will send the HIV self-test kit to you. Not self-test kit, actually HIV test kit to you. And then we schedule the time so that we can meet again and then go through all the HIV self-testing process together under supervision by the counselor. In this model, we named the model online supervised HIV self-testing, and we use the online platform which allows the counselor and the clients to meet online in their own privacy. And then we allow the client, the counselor to provide real-time support, go through the HIV testing steps by steps with their counselor until they get the final test results, and then do the post-test counseling, everything through the online channel. And it has been quite interesting to see the preliminary data that under the online supervised HIV self-testing, we have detected a higher prevalence of people who chose by themselves to go to this online model. And we also reach people who are more likely to be first-time tester. So there are potential to use technologies to increase the recruitment and increase the testing rate among key populations. And the use of online technology can also help us a lot. We know that we have many successful online reaching campaigns to MSM, to transgender people, but how to convert that successful reaching into successful recruiting them into getting actual HIV testing or even PrEP service. That's something that we can further explore on. So last year, Adam's Love team has explored its O2O, online to offline campaign, and it is very interesting that when you see people who we reach them online, and then we offer them the opportunity to do e-booking, and then they receive this e-ticket with the QR code, which they can use to present to the staff at the clinic, and then get fast-track service. They don't have to repeat those online, those pre-test counseling again. They can just go through the testing and then get the post-test counseling process. It is very interesting to see that 76% of people who did the online booking, they actually came to the clinic to do HIV testing, and half of them decided to start PrEP. So with the success of using many various innovative models, what I mentioned is just a few examples. We know that many more people will come to us for HIV testing. We will diagnose many more HIV positive people. So we begin to hear a new set of questions. How many more patients can our hospitals handle? And we know that the majority of patients in any hospitals, almost more than 80 or 85%, are patients on ART, on stable ART. So can we see these stable patients less frequently? And here, the task sharing concept, the differentiated care concept, can probably help delegate roles between hospitals and communities. So in this year, not this year, last year and this year, the country will seriously explore the differentiated care model. And in this model, it will allow us to re-look at our service delivery system and use the client-centered approach in order to simplify services to fit the preferred services of various groups of clients. So we are not saying that this is a lump sum PL-HIV clients. We are going to provide or offer the same service for everyone. There are various groups of PL-HIV. And that will certainly help reduce the unnecessary burden of the healthcare workers, and then will allow us to use that limited human resources and financial resources to then refocus them to people or clients most in need. For example here, if you have a stable patient on ART, the patients may have been with you for more than 10 years. Do you still want to see them every 2 months or 3 months? No. Do you want to see them every 6 months? Or probably you can see them every 12 months if you can delegate certain roles to qualified and trained community health workers. So, for example, you may want to pre-prescribe the prescription for the clients, and then they can go to the community-based organization, see a trained community health workers, and receive ART refill every 3 months or every 6 months, and then come to see you only once a year. That could be something that in different settings, even in Thailand, in different provinces that we have explored this, they may prefer different models. So this could be something that we can explore. Now it's my turn to ask questions, because we have been doing a few cohorts, test and treat cohort, and we realized that the burden of asymptomatic STI is very, very, very high. If you look at the data from the community-led test and treat cohort here, around 1/3 of clients coming to any community-based organization will have one of these STIs: syphilis, gonorrhea, chlamydia. If you look at HIV-positive clients, it's almost 60%. If you look at HIV-negative clients, it's almost 30%. It's just because our country are still depend on gram stain culture or testing only for those who have symptoms. That we didn't realize this before. But now that we know about this, what's the next step? How can we access a cheaper molecular-based STI testing so that we can really implement a symptomatic STI screening program? So again, last year and this year, it's the time that we will explore more of how we can use effectively the point-of-care molecular-based technologies. And this could be for gonorrhea, chlamydia, which with this point of care molecular-based technology, we can pool samples, and we know that for MSM, for transgender people, to pool sample, that is really important because it can save cost a lot because you have too many compartments that you would like to get the samples from. This could be urine, this could be anal swab, this could be oropharyngeal swab, or this could be neovaginal swab, right? So if you have to use or base the service on the conventional molecular-based, machine-based platform, you will have to do 4 different testing on one person, and that will cost you a lot. And the turnaround time, because of the complexity of the assay, we also have for you to tell the clients to wait for 3 more days or even a week or 2 weeks before you get the results back. And that's not the way that we control STI. That's not the way that we can manage STI. So with this machine, we can pull samples together. We can get the turnaround time, the result back within 90 minutes. And we can also do the same thing for other related disease within the same package. For example, TB, HIV viral load, and even for hepatitis C. And now the question from a few great colleagues who have been doing the test and treat cohort with us is that we know that it is feasible to do test and treat. However, we also still seeing high HIV incidence among this cohort, even though we are doing this cohort in a setting where we are providing high quality risk reduction counseling, condoms, lubricants, STI management. We are still seeing very high HIV incidence in this population. So how soon will the test and treat coverage be high enough to reduce HIV incidence? No one knows, because it depends on how soon we can scale up the test and treat, how soon we can change the mindset of the doctors and nurses in our country to go for treatment for all. However, it is certainly true that we need to scale up both the facility-based test and treat models and both the community-led health service model. And for community-led health service model, it is also important that this is to be scaled up with sustainability, to accreditation, to legalization, and to identifying domestic financing mechanism so that we can ensure that the investment that we have put today will remain decades from now and can be also adapted for other chronic diseases as well. But while waiting for the scale up to come into effect, because before we see the HIV incidence reducing, we know that it is time now that we will have to use PrEP, and STI integration into the program more effectively. We have these tools already, but we just don't use it effectively. So just to give you some pictures of how PrEP programs in Thailand have been evolving. We started, we launched the guidelines October 2014. We have the first PrEP program called the PrEP 30 service, which is the fee-based service for PrEP at the Thai Red Cross Anonymous Clinic in December 2014. So at the end of 2014, we only have like around 10 PrEP users in the country, and this is an initiation from Dr. Don Colby at the Thai Red Cross AIDS Research Center. But then by the end of 2015, we have around 300 PrEP users in the country, and this is because of the PrEP sub-study under that 2 parallel test and treat projects along with the PrEP 30 clients. And by the end of this year, last year, 2016, we have approximately 2,000 PrEP users in the country, and we can see that the number of PrEP service delivery sites has increased quite dramatically over the past year. But last year, the Thai Red Cross AIDS Research Center was almost put into a lawsuit by the Thai FDA because of the launch of one of these PrEP educational video, which portrayed PrEP use in a serodiscordant gay couple. And it was very depressing to know the reason behind the initiation of this investigation of this video. that this is the video that is against the Thai Medicine Advertisement and Sale Act. The reason behind this is that they feel that if they allow this PrEP video to go out into public, many other breast enlargement products, penis enlargement products in the country will want to do the same thing. So you see, it's very depressing that people compare PrEP efficacy from many randomized controlled trials to prevent someone from getting HIV to the unknown efficacy of these enlargement products. So it pointed to us that many more efforts are needed to educate the community, to provide correct knowledge, to provide awareness, and also to create positive attitudes towards PrEP in the communities, not only for potential PrEP users, not only for potential PrEP prescribers, but for the overall community. And lastly, as I mentioned before, and as you can see through my presentation, our efforts are mainly focused on MSM and transgender women. And we actually know nothing about test and treat among people who inject drugs, know nothing about PrEP in other populations such as female sex workers or people who inject drugs. So this year will be the year that we will seriously explore the test and treat model, the PrEP model, and probably like a whole person model for other key populations. Yeah. So in summary, I would like to just give you a few take-home messages. The test and treat to the level of even 95 will certainly take time. And unfortunately, it will not get you to the ending AIDS goal. We have to be very clear about this, not be too optimistic. So it depends on you if you would like to take action now or you would like to wait and see if that's true for your country. Yeah. These are the list of actions you may want to take. Number one is to open your mindset, engage more the community colleagues, and aim towards the community-led health service model. This will be very exciting, and I can assure you that it is feasible. Number two is to use technology to its full potential. Technology can really help you fill the gaps along the reach, recruit, test, treat, prevent, and retain cascade. I just gave you some examples of how to recruit, how to test people using online technology, but it can certainly help with prevention. It can certainly help with retaining people in the program. Number three is to explore differentiated care concept, because this is something that countries in our region need it. And I think that it is very important to start now so that we can refocus our limited resources to people who are most in need. Number four is to integrate STI, seriously integrate STI into HIV services. And hopefully more demand in our region will result in more affordable supply. Number five is to not be too afraid of PrEP and PEP. The first thing to do is probably to clear your mind. Address your own concerns. What are you concerned about PrEP? What is your concern about PEP? And then use your knowledge in a non-judgmental and respectful way. And lastly, is for any country to start thinking seriously about transition plan. And once you start talking about transition in your country, wisdom in your country, unity in your country will certainly come to you. And I would like to end by thank you all partners who have made all the works in our country possible. Thank you very much.